Good afternoon. My name is Johanna Kemmener, and I'm an ST4 Public Health Registrar working with the Thames Valley Health Protection Team. This webinar will cover measles and contact tracing in primary care settings. So contact tracing can be a lot of work. So what is the rationale behind contact tracing for measles in GP settings? Well, measles is transmitted through the respiratory route and it's extremely infectious with an R0 or basic reproduction number of around 15 to 20, which basically means that one infected person with measles could infect up to 20 other people in a completely susceptible population. There are certain groups who have increased risk of more severe measles disease and complications and hospitalization, including immunosuppressed individuals, pregnant people, and infants under the age of 12 months. There is post-exposure prophylaxis, and it can be effective if given as early as possible and ideally within 72 hours. Let's consider a scenario where a potential measles case has attended a primary care setting and was not isolated. Well, we know that measles infection can spread easily in healthcare settings between patients in waiting areas, for example, or between staff and patients. And the process is as follows. On clinical suspicion of measles, the local health protection team must be notified. The health protection team will then risk assess all notified measles cases. And for higher risk cases, for example, probable cases or confirmed cases, the health protection team will then in turn contact the GP surgery directly to discuss contacts and advise on post-exposure prophylaxis. GP surgeries should perform their own risk assessment and contact tracing following a measles exposure with the help from the health protection team if needed. What are the steps in terms of the risk assessment? Well, first of all, the period of infectiousness needs to be established. And when we think about the date of rash onset as day 0, then the period of infectiousness would be from the 4 days before onset of rash and for 4 days after rash onset. When this has been established, then the date or dates and time of exposure need to be considered. So when and at what time was the measles case in the primary care setting during their period of infectiousness? And it could be that the case has attended the primary care setting more than once. So any date or dates and time of exposure need to be considered. And then thirdly, it needs to be assessed where the measles case has been in the primary care setting. So have they spent a considerable amount of time in the receptionist's area, for example, or in the waiting room, or have they been seen first by a nurse in one room and then moved to another room to see a GP? So basically the measles case's pathway in the primary care setting will need to be established. Once that is done, then all the contacts should be identified in the following order of priority. Immunosuppressed contacts, then pregnant women and infants less than 12 months old, healthcare workers, and then lastly, healthy contacts. The health protection team will send an email with very helpful documents, including, for example, a document with a blank line list to collect all the names and details of those contacts that have been identified in the different risk groups, and also a really good risk assessment document that includes all the key actions that need to be taken in terms of the risk assessment of those different groups, and any key actions need to be that will need to be taken around management. So let's start by looking at immunosuppressed contacts. Well, whilst most transmission events require face-to-face contact, transmission through more casual contact does occur, and for immunosuppressed individuals who are more likely to develop severe measles disease, it is particularly important to consider even limited exposure. So a key message here is that for immunosuppressed contacts any level of contact should trigger an assessment of an immunosuppressed contact. And when we talk about immunosuppressed contacts, we don't mean those, for example, who have a steroid inhaler for their asthma, but we're talking about severe immunosuppression. And I will speak about this in more detail later. All immunosuppressed patients are at risk of severe measles and should be considered for intravenous immunoglobulin, or in short IVIG, following any exposure to measles. And IVIG would need to be sourced from NHS hospital pharmacies and not from UKHSA stockholders. The effectiveness of IVIG is likely to be higher when given as early as possible following exposure, and ideally within 72 hours, though it can be given up to 6 days following exposure. There might be cases where an immunosuppressed patient has been the exposure has been recognized late, for example, or who are found to be antibody negative between 6 and 18 days after exposure. And in those cases, a discussion with a specialist caring for the individual should take place, and IVIG may be considered in order to attenuate infection. As mentioned, for immunosuppressed individuals, the prophylaxis will depend on the level of their immunosuppression and the likelihood that this patient would have retained any pre-existing measles immunity. And therefore, we're dividing immunosuppressed contacts into two groups, Group A and Group B. Group A are basically most patients with immunosuppressions, and those are the ones who are likely to develop and maintain adequate antibody levels from prior vaccination or infection. And examples include, for example, those with HIV infection, those on oral corticosteroid therapy, or those receiving chemotherapy or radiotherapy for malignant disease. Patients in Group A should be assessed urgently for the need of IVIG. If patients in Group A, if they had a previous positive measles IgG at any time, so either prior to or since diagnosis or treatment, or at the time of exposure, we would consider them to be immune and they would not need IVIG. However, if they don't have a positive measles IgG test at any time, then an assessment of their susceptibility needs to be urgently undertaken. And that assessment depends on their age and their history of measles infection, vaccine status. And there's a whole list and a wonderful table in the National Measles Guidance. So no worries, you don't need to know this by heart. This just needs to be looked up. Then we are looking next at patients in Group B. So immunosuppressed patients in Group B are those with even more severe immunosuppression, and those are the ones who may have lost or may not maintain adequate antibody levels from prior vaccination or exposure. And here we're dividing Group B into two subgroups. Group 1, subgroup 1, are those, for example, patients on or after completion of chemo for ALL, or patients who might have received a solid organ transplant, and so on. And also here, the management, it depends on whether they have a positive measles IgG, though for those patients in Group B1, if they have a documented positive measles IgG since diagnosis or treatment end, no IVIG is required. But for everyone else in this group, urgent IgG testing should be conducted at the time of exposure. And if it's not possible to test within 72 hours of exposure, they should get IVIG. And lastly, Group B2 are those with the most severe level of immunosuppression. For example, those include patients who have received hematopoietic stem cell transplant within the past 12 months. And for those patients, they should be given IVIG regardless of previous measles IgG results and without the need for testing. So next are our pregnant contacts and infant under the age of 12 months old. And here the management depends on the time of exposure, the type of exposure, the age of the contact, and their history of vaccination or infection. So if we are within 6 days from the exposure event, where the exposure date is day 0, all the pregnant women or babies under 12 months should be identified and assessed and managed if they had a significant exposure. So remember, for immunosuppressed contacts, any level of exposure would trigger an assessment. However, for pregnant people or babies under 12 months, only if they had a significant exposure. So how is a significant exposure defined? Well, it's defined as any face-to-face contact or more than 15 minutes contact in a small confined space, for example, the same treatment room. You might ask, well, what if they have spent more than 15 minutes in the same waiting area? Well, then please clarify the size of the waiting room as part of your risk assessment. If the waiting room, for example, is larger than a standard room in a house or is well spaced, then this would be unlikely to be considered an at-risk space. If pregnant women or infants under the age of 12 months are identified, and if they had a significant exposure, for immunocompetent infants and pregnant women who are normally managed in the community where intravenous immunoglobulin is not really practical, intramuscular HNIC, so human normal immunoglobulin, is recommended. And the rationale for providing HNIC is to attenuate rather to prevent disease. HNIC can be sourced from the Rabies and Immunoglobulin Service at UKHSA Colindale and from a small number of stockholders across the country, the list of which is available. So the assessment and treatment of pregnant women and infants really depends on their age. And in the case of pregnant women, also their history of measles infection or vaccination history. Same for infants under the age of 12 months. Here, the management also depends on age. For example, infants under the age of 6 months would be assumed susceptible and they would need HNIC, ideally within 72 hours, but up to 6 days. Whereas infants who are 9 months and older, for example, would get an MMR vaccine as their post-exposure prophylaxis, also ideally within 72 hours of exposure. All of this information can be found in the National Measles Guidance, so you don't need to know this by heart. What I've spoken about earlier now in terms of the pregnant contacts in infants is the management depends on whether the exposure event happened, like within 6 days. But if more than 6 days after the exposure have passed, then it would be too late to offer post-exposure treatment and a warn and inform letter should be sent. Those pregnant women or infants under the age of 12 months should watch out for symptoms and they should be isolated if they attend the surgery with compatible symptoms within 21 days from the date of last exposure. So our third group are our healthcare worker contacts. And also here we are looking at significant exposure, which is defined at any face-to-face contact or contact of more than 15 minutes in a small confined area. What is also important to consider is that that all healthcare workers, all employees, all staff members should be considered in this risk assessment. Not only nurses and clinical staff. So staff members may include receptionists or cleaning staff, or even builders who might have worked in the building in the same room at the same time. If a contact has occurred, it's important to firstly check whether the healthcare worker is immunosuppressed or pregnant. If they are, then the algorithm for immunosuppressed or pregnant contacts should be followed. If they're not, then their immune status should be checked. And they should have evidence of 2 doses of measles-containing vaccine or a positive measles IgG. If the healthcare worker has evidence of protection, they can continue to work normally. If they don't have satisfactory evidence of protection, they must be included from work from the 5th day after exposure until 21 days after last exposure. You could consider offering rapid testing after exposure. And here, if the measles IgG comes back positive and the result is available within 7 days of exposure, those healthcare workers can continue to work. And this is because it would be considered too early for the IgG to be positive due to the recent exposure. Where MMR vaccine is given post-exposure, it's unlikely to prevent the development of measles, but if the staff member remains symptom-free for at least 14 days after MMR was given, they can continue and they can return to work at that stage. If there are any concerns around staffing levels, so if there are several staff members that need to stay home following an exposure event, and staffing levels might lead to concerns for the safety of patients, for example, then the risk assessment should be jointly reviewed with the health protection team. So next steps are all other contacts. Other contacts with a significant exposure event and who are neither pregnant nor under the age of 12 months nor immunosuppressed, they should ideally, it should be they should have their MMR vaccination status checked, and if they don't have a complete course of MMR, then they should receive their first dose, ideally within 3 days if possible. Again, those 72-hour window. In general, a warn and inform letter should be sent to everyone in the waiting room at the same time as the case. And this should be done as soon as possible and up to 21 days after exposure. And I can't stress enough the importance of warn and inform, even if the exposure is identified after day 6. And this is because whilst obviously sending mass warn and inform information is time consuming, it is really worthwhile. We have found these warn and inform really helpful in containing clusters and ongoing transmission as people do alter their behavior. For example, they avoid contact with vulnerable people, they might be more mindful of symptoms, and if they seek healthcare after developing some measles-like symptoms, they can be isolated. So just to reiterate some key points around infection prevention and control. For staff members, ensure up-to-date OCC health records for all staff members, and all staff require 2 doses of MMR or a positive antibody test for measles and rubella. Patients should be triaged, if possible, before they arrive in the surgery, and those with a fever and a rash illness should be isolated on arrival in surgery before they're being clinically assessed. And it's really important to make sure that patients' vaccination records are up to date. And again, just to reiterate the process, so if there is a clinical suspicion of measles, the local health protection team must notify it, and the health protection team will then risk assess that measles case. And for higher risk cases, the health protection team will then again contact the GP surgery directly to discuss contacts and advise on post-exposure prophylaxis. GP surgeries should perform their own risk assessment and contact tracing following a measles exposure with help from the health protection team if needed. Thank you very much.